Hello everyone and welcome to the 9th webinar in the series being put on by the Provincial HSJCC. Hopefully you can hear me okay. My name's Mike and I'm a co-chair of the Provincial HSJCC along with Katie Almond, who's unfortunately not able to join us today. So I just wanted to give a special thank you to the Evidence Exchange Network and especially to Matt for providing support and for hosting this event. To ask any questions through the webinar, you can actually type them in on the box at the side of the screen. It should say type questions here. You can also save them till the end because we will have time for questions after the presentations. All the PowerPoint presentations will be emailed out to you after the event. They'll also be available on the website, the Provincial HSJCC website. And a brief survey at the end, and we'll have a link to that that you can click on. Again, you should be able to hear us hopefully through your speakers. If you do have problems with the sound, let us know by typing a comment in the question box. And if you could too, let us know if there's more than just yourself joining us. We want to get a sense of how many folks are going to be participating in the webinar today. Just a quick overview of the presentations. I'm going to give you a little bit of background on the HSJCC and what we do. Then we're going to have our Northeast Regional Outcomes Project provide their presentation for the bulk of the session. And we'll have some time at the end for comments and questions. So the two presenters that will be speaking about the Court Outcomes Data Project are Sarah Gauthier, and she's the Justice Program Coordinator at CMHA up in Sudbury, Manitoulin. And she's the co-chair of the Northeast Regional HSJCC. So that's up in the Sudbury, Parry Sound, Sioux region. And she's going to be joined by Helene Philbin-Wilkinson, who's the Director of Dual Diagnosis and Mental Health and Law Services at North Bay Regional Health Center. And she's a member of the Regional HSJCC as well. So the HSJCC network, for those who don't know, was established based on a provincial strategy to coordinate human services and criminal justice systems in Ontario in 1997, and was responding to a recognized need that in the province of Ontario, we need to coordinate resources and services to play more effectively for people who are in conflict with the law, and a priority was placed for people who are experiencing mental illness or developmental disability, acquired brain injuries, or drug and alcohol addiction, and involved in the justice system. And it's really a model of shared responsibility and collaboration to help assist those who are experiencing both mental health issues and involved in the justice system. So the HSJCC network, I think, now comprised of probably over 1,500 members to the province of Ontario, with 43 local HSJCCs, 14 regional, and the provincial HSJCC. Each group is voluntary, and it's a collaboration between social service providers, mental health folks, addiction organizations, partners from the justice sector. I know we have folks from corrections and policing, as well as lawyers and judges on the committees. And it's really a chance for folks from all over the justice system to come together and collaborate and to coordinate services and share ideas. And of course, we're funded by our friends at the Ministry of Health and Long-Term Care. So the provincial HSJCC is a meeting of all of the chairs and representing their regional groups. We also have ex officio members who come and are part of that committee from corrections, policing, Legal Aid Ontario, and community networks and specialized care. We have ex officio representatives from 5 provincial ministries, the Attorney General, Child and Youth Services, Community and Social Services, Community Safety and Correctional Services, and Health and Long-Term Care. So we really get to benefit from having an interministerial perspective and guidance in our work. And if you notice, there's the little bird on the left of the screen. This So you can actually follow Provincial HSJCC on Twitter now, that newfangled Twitter. So if you're on that, it's a great resource to keep up to date with what's happening with that group. So if you want to share with your colleagues and your coworkers, we have some other upcoming webinars planned. On March 26th, from 12 to 1, we're going to have a webinar focused on pre-charge diversion. And there's webinars planned for April, but the exact time and date's not yet determined. And that's going to be on the Hamilton Rapid Response Team. So stay tuned for further details about those webinars. And as I mentioned earlier, if you're not already familiar with it, all of the past webinars are archived on the Provincial HSJCC website, along with an extensive library of resources and information on the work of all of the local and regional HSJCCs. So I'd encourage you to check it out. And for more information on EENet, you can visit their website, which is there as well. So without further ado, I'll introduce you to the two presenters for today, Sarah Gauthier and Helene Philbin-Wilkinson.
Hello. Thank you, Michael, for that introduction. And so I wanted to thank everybody and welcome you to this presentation on our Northeast Regional Outcomes Project. Hopefully everybody can hear okay. I think for me personally, this is a very important and very exciting project that I'm very proud of. It's one of the first of its kind. It's unique in the province, around where we have multiple organizations inputting performance data into an online portal using well-defined common measures for our mental health and justice programs. We're going to talk about the Northeast for those that aren't familiar with our area, background on the project and the development process, give you an idea as to what the current measures that we are tracking, some highlights around the regional district trends that we've been able to pull out from the data, as well as the implications of this project and the lessons learned. And then finally, we'll end with, I think, which is probably the more exciting part, which is an online tour of the actual portal itself, so I can show you the capabilities of this project and how it works. So I'm going to pass it over to Helene, and to the next slide. There we go. So good afternoon. The Northeast region, as some of you may or may not know, is quite large. It spans 400,000 square kilometers, and it also represents about 40% of Ontario's land mass, with only 4.2 of the province's population. So we have significant geography. In the winter, we have inclement weather, significant barrier for travel, rely quite a bit on technology. Compared to the rest of the province, just for your information, we have higher rates of substance abuse, smoking rates are higher, a number of medical chronic conditions. We have a higher number of unscheduled ED visits for mental health and substance abuse issues, as well as an overutilization of hospital beds as it relates to mental illness and, in particular, self-injury. And this, of course, is for our population aged 15 years and older. To give you a sense of the scarce resources we have spread across this large region, we have 25 hospitals. 4 of them are Schedule 1s, and plus the Regional Mental Health Center in North Bay. We have quite a few community-based mental health and addiction services serving all of the region, and I just want to highlight that the region goes as far north as the James Bay coast, so we have a number of agencies as well, and 1 CCAC serving all of the Northeast. Go to the next slide. It gives you a visual overview of the Northeast, and it's so that it is the Lynn area and the district that it serves. So we have Nipissing, Sudbury, Manitoulin, Sault Ste. Marie, which is Algoma, the Cochrane and Timiskaming districts, and then the James Bay coastal communities, and that particular area is significantly large. So as we move through the next few slides, we're going to focus on the unique partnership that North Bay Regional Health Centre has with 8 community agencies in terms of the justice program and the community mental health courts. We have 24 court locations spread across this quite large landmass, and so we have been working for approximately together 15 years through a formal next slide, through a service agreement 2000 for the purpose of initially, as we began to establish the justice programs across the region, we had a formal agreement back then. And sort of the key components of that agreement, including outlining the roles and responsibilities, ensuring timely access to forensic psychiatric assessments, as well as diversion programs having timely access to community-based resources. So we have been collectively working towards the common purpose of optimizing our resources, and we're now moving toward this sort of new era together as we're tracking common service trends and outcomes. Initially, throughout the last decade and a half, we've been struggling with inconsistent definitions amongst the different agencies, and we were always sort of unclear in terms of the rationale for the data collection. Although the service agreement talked about measuring apples to apples, we had inconsistent methods of reporting, and folks were using different definitions to define diversion, alternate diversions, et cetera, et cetera. And we also, so that resulted essentially in an unclear understanding of what the overall performance of our partnership was in terms of how we were impacting the Northeast. And obviously it hampered being able to validate the trends to inform our funder. So having data certainly helps not only to track the trends and the service demand, but it certainly helps to communicate back to the our respective boards and our funders about what how well we're using those resources and what the impact is. The project has also helped us to hold each other more accountable in terms of the partnership. So with any partnership or service agreement, it needs to be revisited over the years, and I think we've revised our agreement perhaps 3 times, and it's now time to revise it again, given the sort of the collective movement or direction we're taking in terms of holding ourselves accountable as a joint system of care from a justice perspective. So we are certainly wanting to communicate to our stakeholders how we have improved access and the connections to the various services that we interface with in the different sectors. Next slide. This represents all of the community agencies who have endeavored over the decade and a half to stick it out and who have committed to this particular justice outcomes project. And so no easy task, but we have secured commitment from all of our respective agencies and senior leadership to move forward with this innovative way of measuring performance. Great. Okay, next slide. So I'm going to just give some background, it's Sarah, I'm going to give some background on the project itself. piggybacking on that, we had this common goal of wanting to validate the work that we're doing in the region. How do we back that up with our data? So we started asking the questions, how do we know that we're making a difference? And how do we measure program and system performance? So one of our first tasks was to take a look at what was being done in the rest of the province. And so we surveyed many of the mental health and justice programs, mental health court worker programs across the province. And we realized very quickly that there was no standard measures or common definitions. We were all collecting statistics, or caseload statistics, as you might call it. So numbers, how many individuals served, how many diversions we were doing. But it doesn't necessarily give us any quality to the data. How are we actually doing? Were we doing a good job at servicing these individuals and providing diversions, et cetera? And there wasn't any kind of provincial mandate to look at the quality piece for these programs that have been funded since around 2000. So we went to the Northeast Regional HSJCC with this idea around let's look at common definitions for our region so that we can start comparing apples to apples, as Helene mentioned. A successful diversion in Sudbury may mean something very different to a successful diversion in North Bay, for example, or the Sioux. So we wanted to be able to look at not only our individual programs, but as the region as a whole and see what's happening there. So with the support of the regional HSJCC and North Bay Regional Health Center, we started to kind of move forward on this project. Next slide. Just to give an idea in terms of the timeline, there's always some challenges with trying to get multiple organizations to come together for any kind of project. And because we had nothing, no kind of baseline to go from, we're basically starting from scratch. So CMHA Sudbury was already embarking on this performance outcomes journey, shall we say. And so we went ahead with developing 3 particular measures and went live with measuring and gathering that data in 2012. After about 6 months of data collection, we brought it to the partners and demonstrated to the other court programs and HSJCC. And after having something visual to be able to see the scope of the project and what the implications, what this actually meant, the buy-in was there. So the partners agreed to the development of an actual regional portal and building on the existing measures that CMHA Sudbury had started. This agreement included engaging a consultant to further develop those measures and host the online portal, which also included then a financial commitment from each of those organizations. The actual portal, Northeast portal, went live April 1st, and then phase 2 of further development in April 2014 was actually funded by the Northeast LIN to enhance the current measures and further develop some of those system outcome measures. Next. Quick visual that represents a bit of the development process when we're looking at quality improvement and outcome measures. So the first step was we really needed to take a lot of time to make sure that our definitions were sound and actually were based around performance, that we were looking at, okay, what does this definition mean and how is it going to tell us that we're doing a good job? How is it going to measure our performance? So that was the first step, and probably the most intensive step was around that, defining the actual measures. Then we're looking at the actual data collection itself, which we have begun. And once we start to get some of that data in there, we can start to analyze it, which is around the phase we're in now with 2 years worth of data and some of the new measures a year in. We're looking at analyzing the data. The next steps will be, will be around improvement planning and then that quality control piece, as we're constantly striving to improve our programs. And as the trends and the different things happen, we want to be able to adjust to those and be able to provide quality service. Next, please. So this slide represents that development phase around defining the outcomes and the measures around what is it that we wanted to measure. And I apologize, it's not as clear. It was hard to get a lot of this information on one slide. And it looks at, so what is it that our goals of the program, we want to reach more people, we want to be able to increase those diversions. If you look from left to right, you can see kind of those headings on the top around we want to increase the amount of individuals that we're able to provide support to. We want program success, ultimately client success, and then have that system impact. So beneath those 4 goals, the group identified, if you'll go back to reaching more people at the top left of the slide, you'll see beneath there sort of 4 mini yellow triangles that represent the specific measures that we came together as a group to define. So increased diversion of adult clients, increased diversion of youth clients, and so on and so forth. So we hammered out those specific indicators under each heading. Program success as you move through, a couple of little yellow triangles there, looking at the successful completion of diversions, etc., and then client success with charges being withdrawn, more successful transitions and better connections to the community. Ultimately, and I want to go back to the partnerships with purpose principle, is that ultimately the agencies as well as the hospital involved in this partnership are looking at reducing recidivism rates, improving the patient or the client experience or satisfaction, and remaining accountable not only to each other but to the system and our funder, and building a sustainable system of care. So you'll see once we we're able to sort of showcase the data that we're entering and analyzing so far, and when we begin to move into the quality piece, we're going to be able to start setting some benchmarks for ourselves in terms of sustaining, a minimal rate, let's say, of successful diversions from court as one example. So we're not quite there yet, but we are establishing some benchmarks for our regional system. Great. Next slide. So I just want to highlight the measures that we currently have in place. So phase 1, those 3 measures that I mentioned, the initial ones, looked at the diversion success rate, and this looks at how successfully are people being diverted from the criminal justice system into the mental health system. And there is a definition of what success means, and so that it's common across our entire region when we're looking at this data, and it has to do with the charges being withdrawn. And then within the portal, there is a formula that then calculates that for us once the data is entered. The alternate diversion or alternate disposition success rate, our court workers do a lot of advocacy in our court system, and there's a lot of individuals that may not be eligible for diversion for a variety of different reasons. And we wanted to be able to, how do we measure all that other work that they're doing? And so this looks at, are we successful in advocating for improved dispositions? And it could be a more tailored disposition to somebody's needs. It could be probation versus jail, those types of things. And the admission aversion rate, this is a very interesting rate. This has a lot of impacts around program, client, as well as the system impact. And this has to do with averting people from a fitness assessment specifically that didn't necessarily need to go. One of the system pressures as to why these programs were funded many years ago was there was a lot of backlog in the system with individuals waiting for an assessment that they may not have necessarily needed. Just maybe some not quite understanding the purpose of the fitness assessment. So our workers do screenings and make recommendations to the court as to whether or not an individual should go for a fitness assessment. And so this measure looks at how are we successful in doing that. Next slide. For phase 2, we tackled a couple different ones. We enhanced some of the current measures as well as created some new ones. This idea of recidivism is definitely something, as Helene mentioned, a huge system impact that we hope that our programs are making. Very difficult to actually measure. So in terms of a true recidivism rate, what we looked at is, what we could actually measure is how many people while on a diversion were known to reoffend within the diversion period. So while they're engaged in our services and our program, are we preventing or assisting with that recidivism rate? The fitness recommendation consistency rate, so this looks at, so if we do recommend that an individual goes for a fitness assessment and they go, what's the physician's recommendation, and are we consistent with that if we had said there were fitness concerns and the physician comes back and says, yes, I believe there are. So looking at our program performance around that. The release from custody rate, our workers, again, do a lot of work with helping individuals get released from custody at the bail level. It could be advocacy with our crowns or courts, setting up bail release plans, connecting them to services in order for the Crown or the Justice of the Peace or the judge to agree to a release. And this rate looks at our the release rate based on our intervention and involvement. Next. So I just want a couple quick mentions around the data collection itself, because this is something that is unique. It hasn't been done, and there's always some concerns around how do you actually collect this data, and how do you maintain confidentiality when you have multiple organizations putting into one database. So there are no unique identifiers that get inputted into the actual database. Each agency uses their own client database reference number. Clients get assigned a number when I input into my database, for example, and that's the number that I put into the portal. It's identified by agency and by court. As Helene mentioned, many of the agencies cover multiple courts, so it helps give us some trends around what's happening within the different courts. And then we also have added in some of this really rich kind of information that it gives us around demographics, sex, diagnosis, that kind of thing in the needs categories. So that's going to help us look at when we start to see trends, we can then look at that part of the data and maybe give us some indicators as to what's happening, and also inform where do we need to start looking at improving our performance. Next. So around the common language piece, you know, there are existing measures out there. There are existing tools that are being used. For those that are Ministry of Health funded, we all have to use the OCAN. And so when we were looking at diagnostic categories, for example, we thought, well, let's use what's existing out there. Let's use the language that our funders are currently using so that we can continue to talk apples to apples with some of these items. So we used OCAN categories for diagnostic category, for example. In order to maintain the actual data integrity, the portal, you need a username and password to get on. All the fields are mandatory, so you don't start getting blanks in the data. The individuals that are entering the data, which are usually the frontline workers, they can't change anybody else's data. You can only upload your own and update your own. So that maintains some of that integrity piece. And finally, it's integrated into the current practices. So each agency has a little different way of how and when they input the data, but it's integrated into our practice. For example, our office, each worker, when there is a successful diversion, for example, at court, charges get withdrawn, they come back to their office, they have to do their regular paperwork, case note, update their CDS information, and then they take 30 seconds, log onto the portal, do a quick enter of the data, and it's done. So it's not this big extra project or extra work. It's all part of what we would normally be doing anyways. Next. So this is just a quick highlight of what kind of data we can pull out of the portal, and I'll give you a more in-depth tour when we get to it. But this kind of gives you, so not only are we getting the rates that we talked about in those measures, on the left-hand side you can see we can start looking at comparing the data from all the different agencies. This is the diversion count, so how many each agency is doing over the time period from 2013 to 2014. We're just started in 2015, but you can see those numbers are fairly consistent. On the right-hand side, this is just an example again at the diversion count. So this is the
the counts of diversion across the region and the types of diagnoses we're seeing with regard separated into the adult, youth, and seniors category. Right, next.
What's really fascinating, at least from my perspective, as we oversee sort of the forensic system and wanting to know a little bit more about what's happening in each of the districts that we serve and validating what we're seeing come through our doors when people are being admitted for assessment, is this particular slide. And I think we're just starting. We just had our partnership meeting a few weeks ago, and we were just really starting to be able to validate with the data some trends that we're starting to notice. And although we've anecdotally perhaps observed some of these trends over the last few years, having the data is very rich for us. So what we're seeing so far, and these are just samples, the youth recidivism rate appears to be higher in the districts of Sudbury and Nipissing. I think across the board what we're seeing is that the justice intervention does increase the success rate of release on bail for people with developmental disabilities. So that, and in fact, when they're not there and there is no intervention, it certainly has a negative impact. The courts are consistently following the justice programs when they're ordering fitness to stand trial assessments, so that's quite nice to see. And from a demographic perspective, we're, and this shouldn't be a big surprise, but nevertheless, the data is validating that more males are in the system being diverted than females. However, that gap is narrow when we're looking at gender among our younger folks that we're seeing in the court system. Next. So again, this is just another example of some of the slides and some of the data that we can pull out. On the left, this is looking at the admission aversion counts, and the diagnosis. So on the left-hand side, this is the diagnosis of the individuals of whom we've been able to divert. And then beside that, it shows the ones that are going for assessment and what those diagnosis categories are, primary diagnosis categories are. So, for example, we're seeing that most of the individuals that are going for assessments are individuals with a primary diagnosis of schizophrenia and psychotic disorders, which is what we hope to see. But the data actually validates that. On the right-hand side, this speaks to what Helene was just talking about around the intervention of the court workers around increasing the release rates for individuals with dual diagnosis and non-dual diagnosis. So we can see that if there is no intervention, an individual with a dual diagnosis in our region has a almost 70% greater chance of remaining in custody. With an intervention, they have that's over 70% chance of being released. So it really validates and demonstrates the performance of our actual program and are we doing a good job in making a difference and assisting people. Next slide. So some of the implications of our project in terms of what we have felt have been beneficial to us as a individual agencies and as a group. First is that the way that we have designed this database is that it combines not only the count, so the quantitative data, but we're certainly starting to look at the qualitative data as we begin to measure the connections to the community and the recidivism rates. Historically, we were all sort of just counting numbers of people served, and although that's a good start, it really wasn't giving us a full picture. So that's the sort of a nice, one of the most important features, I think, of what we've been able to develop. Building on that, certainly the common language, so that we're all speaking the same, we're referring to the terms in the same way. And I'm sure you've all experienced that challenge being in a meeting and people are talking about different outcomes. And I think having different interpretations of what we're expected to measure from one agency to the next is a common occurrence. So certainly this process helped us come together on interpreting the terms in a common way so that we're working towards the same goal. As Sarah indicated earlier, it certainly allows for individual flexibility in terms of your own agency's processes for entering data and reporting data. So I don't think that it hampers the agencies in that regard. I think overall, and we've talked about accountability during this presentation, but it is really, I think what we've done is we've put together an accountability outcome framework that's going to really help us make some more informed decisions about our service delivery. Certainly the evidence helps us to validate the system pressures, which again is key to have in your back pocket when you're speaking with your funder. I think too, and I don't know if we have a slide on that, I don't think so, but when we're talking about aversions from hospital, we're able to quantify that cost savings just as an example to the hospital. Our per diem rate is around $675 a day for an inpatient assessment. And so when you think about the cost savings to the system, and then when you throw in the use of technology to support the system, we have yet to measure that cost savings, but it's certainly an important part of this database to start looking at. And I think we've done some preliminary work in terms of the cost savings from a correctional perspective as well. The per diem rates there are much lower, but nevertheless, when you're avoiding sending someone to a correctional facility, it's also a very important savings to the system and better for the patients or the clients naturally. So I think overall we jumped a slide. But certainly this supports the new, I think, culture of quality, continuous quality improvement that we're all faced with in the current economic climate. And despite the barriers of our own geography and distance and technology, but I think if we can do it, I think anybody can. Just having experienced, it took a long time, but we certainly overcame a lot of barriers. And we, of course, used technology. So I won't go through the allocation of funds because we've already touched on that very important implication. Next slide. So we have put this together in terms of if anyone was interested in embarking in this journey. Certainly the group, and in particular Sarah and I sat down the other day to talk about some of the lessons we've learned. First and foremost, I think commitment at all levels is essential. That was a wee bit of a struggle for us initially coming out of the gates, but if we were to do it again, we'd certainly involve all levels right from the get-go. It's important to acknowledge that agencies have different levels of readiness and resources. Having Sarah and CMHA Sudbury Manitoulin be the initial champion and the ongoing champion really was instrumental, I think, in getting this project off the ground and having the evidence that it works. So Sarah talked initially about demonstrating the data that CMHA Sudbury had initially entered into the portal. I, for one, when I saw that, I immediately jumped in with both feet and said, we've got to do this. Acknowledging the priorities and needs of everyone, and that goes back to just the readiness and the resources, and hammering out the common language very, very early on. It was time intensive, and I think that it has the risk of losing momentum because it does take a while, depending on the number of agencies that you're working with. But negotiating and investing the time very, very early on in the process does certainly improve the motivation to remain engaged. I think it's essential to have the expertise of someone who's very well versed in outcome performance development and then the data management. So we do have our external consultant still working with us and still housing the portal. That way no one agency is overwhelmed with that particular duty. So it does mean that we each sort of pitch in and having the cost divided amongst the 9 partners is certainly a lot more palatable. It does require some ongoing training and support, and it does, I think having that formal agreement was instrumental because it's right there written in our agreement that we've all signed off on in terms of having data that we can share and measure our performance. I think, going back to the champion, I think without having a leader, someone like Sarah, who's persevered for the last couple of years, we've often talked about Sarah herding cats, and it certainly looked and felt that way sometimes. I don't know how she did it, but here we are a couple of years later, and we've got a fairly robust database that we're quite proud of. So thanks to Sarah and then all the agencies that have been responding to her countless emails and phone calls.
Great. Thanks for that. Next slide. So just quickly around future directions. At this point, we're continuing to collect data and starting that analysis phase. Once we kind of get through that, we'll start that quality improvement planning. And because we didn't have any baseline or targets or standard measures established, that we had to set our own based on the data, and those will continue to move as we do the quality improvement planning and hopefully continue to increase those baselines and targets or decrease when appropriate. And so we'll move forward into the online portal because I want to be able to showcase that and give you some time to ask some questions. And once you see the portal, this may help answer some of those questions or provoke more.
Yeah, if you want to talk about some of the questions. The first one was from Allison around diagnostic categories in the graph, in one of the graphs, and if they're based on client self-reports or if they're corroborated by psychiatric reports.
I would say it's a little bit of both at this point. Some individuals we may have self-reported information and others we may have confirmed diagnoses. To access the justice programs for support in the courts or diversion, not all the programs require an actual physician assessment or confirmation of diagnoses. So hopefully that answered that question. And then was there another question?
Yeah, so we'll just go on to some questions. Maybe if you want to take it away.
Sure, I can move into some more of the questions if you'd like. So we had a question from Leslie. She asked, can you address whether there were any issues with collecting this data on youth and having it in a database in terms of the YCGA, or JA, sorry?
So because there's no unique identifiers on the individuals, it's basically just whether or not they're in the youth category, which is categorized from age 12 to 17. There weren't any concerns with regards to confidentiality or around the YCJA component of it.
Okay, hopefully that answers Leslie's question. Brock University also asked if there was any other privacy concerns that you needed to address.
No, I don't believe so. This is where I would have liked to have shown you what it looks like, because then you get a better sense as to how we're able to input this data without having those privacy concerns. So, for example, as I mentioned, the only thing that's in there is a client number that is referenced to each individual organization's database. So only, maybe client number 1234, and that's specific to my database and within my organization. So, and it doesn't give you, there's no date of birth, there's no of that kind of component to give any identifiers.
Okay, Rosie asked, when you're talking about mental health stats, are you working on a self-reported stat as opposed to one that has a physician diagnosis?
And as I mentioned, it's a little bit a combination of both.
Okay, we had another question from Joy, and Joy asked, can you provide us with an example of the type of qualitative example narrative information you are collecting?
So, sorry, I'm just not quite sure I quite understand. Can you repeat that, sorry?
Sure. She asked, can you provide us with an example of the type of qualitative example narrative information you are collecting?
Qualitative and narrative information we're collecting. So, okay, so I'm not quite sure if I'm quite going to get this right, but so along with that information we're collecting around demographics, that kind of piece of it, there's also, we started to try and address this thing around what are the client's needs and are those being addressed? And so that's something that we've been starting to collect. It's a little more difficult, and so we pulled out that needs component of the OCAN to start as a place to start, looking at are we able to address their needs and identifying what are those needs, whether it was housing, substance use, medication, those types of things, and what are the needs at the individual identified, what are the needs that the worker identified, because sometimes those vary, and what was the individual's perception as to whether their needs were met, and what were the worker's perception as to whether or not the needs were met. If that quite answers that question, but.
And what we're finding is that they're different in terms of the worker's interpretation of the client's met needs, and that the client has a very different perspective on their met needs. So they're telling us that all of their needs are generally met, but the worker obviously has a different interpretation of that, and would want to be doing more and would want to meet more of their needs, but it just, I think it speaks to the client's focus on sort of maybe some very basic and fundamental needs that are being met for being released from custody, right, Sarah?
Yeah, the numbers are much more diverse within the release from custody when we're looking at what were the individual's needs and what were did they find they were met? They're saying yes, and I think they're looking at, they were released from custody. That was their main need that was met, and they're, whereas individuals on diversion, the worker's perception and the client's perception are a little more in tune after they've, been working with the individual for several months and that kind of thing at the end of the diversion process.
So am I correct that you guys are using the OCAN to measure the needs when a person enters the program, and then again at the end when they're leaving the program, and assess the changes that would occur?
We're using the OCAN categories as a tool. So it's built into our database, but we wanted to be able to measure it, and instead of reinventing the wheel, we said let's use the common language that our funders are using.
Okay, thank you. So the Ontario Correctional Institute asked if the data were de-identified, how could you or could you rule out repeat customers? Your region is relatively small, and I might guess that you have a cohort of people who have frequent contact with the system.
So it's a very vast region geography-wise. It's a huge region, and we're not able to completely rule out if somebody travels from Sault Ste. Marie to North Bay to, the James Bay Coast, for example. However, within our own organizations, if an individual accesses the diversion program more than once, it's the same, client database. So that can be identified through the client number if it's an individual that's come in another time. But whether if they've traveled to another area, because it is a large geography, it's a huge region, we're not necessarily, because everybody's client database numbers would be different.
Okay, we have another question here. What has been the feedback from the courts and Crown attorneys?
Well, this is something that we are starting to try and promote, and we're looking at trying to get this data out there to showcase it with our crowns. I have spoken to our local crowns, for example, and I believe some of the other areas have also started those conversations, and so far very positive and very feedback and very impressed with being able to actually show the work that we're doing.
I think one of the key messages with our Crown attorneys, and we're sort of planning, hoping to get onto the agenda of the regional Crowns. I think they meet a number of times a year. But one of the key messages we want to drive home is that the justice workers in court have an important role to play, and we can validate now with the data that when they are involved, that there are more positive outcomes, either for if they take the route of the assessment or being connected to their community. So it validates the role of the justice programs in the community courts. So we all know I know that when a court, sort of a seasoned court worker, is absent from court, from a forensic program perspective, we know right away, and there's a wacky order or referral that's coming our way. And so we're going to use it to really validate and reinforce the important role in the community courts.
Okay, thank you. I just want to remind people, too, who are listening, if you could just take a second and enter in the chat box for questions how many people are participating from your site, so we can get accurate idea of how many people took part today. We do have another question. The question is there a limitation on race data collection to Aboriginal only? If so, why are other races not being documented?
No, it's a great question, and it's a conversation that we had during phase 2 of our development. And there's nothing preventing us. We looked at, the Aboriginal versus non-Aboriginal and unknown, which are the CDS categories that the ministry requests. But we had discussed around inputting, again, using the OCAN categories and inputting that. So there's nothing limiting us to do it. Again, it's one of those things, let's start somewhere. And so that's where we started with those categories. And it is something that's on our radar for future development.
Great, thank you. Just a question of my own. So when capturing recidivism rates for folks who are on diversion, do you have a source to use as a comparator to compare them to look at the difference between those who reoffended and were participating in diversion versus those who may have reoffended and not on diversion? Or is there a way to compare it to anything, I guess?
There's no existing data to compare it to. But one of the great things with this database, when we start looking at the actual numbers, so the actual recidivism rate is the measure that we've got. And so, for example, we pulled out, just as a highlight, that, say, Sudbury and North Bay have higher recidivism rates amongst the youth that are on diversion. And then because we've collected all this other information, we can maybe start to narrow down, what are the diagnostic categories of those youth that are recidivating? What are maybe some of the primary issues? So we can maybe look at substance use, for example, and if I can, I could narrow down: is it more males? Is it more females? Those types of things. So we don't have anything to compare it to at this time.
And I think over time we'll be able to compare from one year to the next.
Great, thank you. And I guess my last question was, you mentioned that you'd define diversion because there really is a difference, I think, depending on the agency and who you talk to. That definition of what is a diversion. Is that something that you can share or send out to other folks that may be helpful? We're trying to capture some stats.
In terms of what is a mental health diversion?
In terms of defining, I guess, clearly what is a diversion and what's not.
Yeah. So our mental health diversions, I can give you a brief and it can be sent out, is what we defined it as is when somebody is on an actual formal plan that the Crown Attorney has agreed to, that has been developed with the justice workers and the individual for a set period of time. Usually the plans, different areas have different, depends on the Crown's office, or the charges, anywhere from 6 months to a year perhaps. So it's an actual formal mental health diversion plan. And then at the end of that, the success rate is based on whether, if they successfully completed that plan, their charges are withdrawn.
Great, thank you. So I don't think we have any more questions, so I'm gonna wrap it up. And I want to let folks know too that we're going to try to make some screenshots or video available of the portal walkthrough so that you can see that, since we weren't able to get that working here for you today. And just really to thanks Sarah and Helene for presenting today. And there's a great quote, I think it's Edward Deming, who said, in God we trust, all others must bring stats. So this helps to capture, I think, that great work and document that in a meaningful way. So thank you very much for sharing this with us today. All the presentations will be available on the HSJCC website, and the PowerPoints will be emailed out to the participants. Also ask you to take a moment and complete the survey. You'll see a little link to it there. It's a SurveyMonkey link, and it'll take a couple minutes just so we can get your feedback. So thank you very much for participating today, and stay tuned for our future webinars. We'll be sending out information about that soon. So thank you very much.